sessions. Half an hour seems like a long time, but it never is when we get going. So thanks everybody for letting us know where you're joining us from. I'm just going to drop something into the chat in case anybody wants to look at it whilst we're running through here. Okay, so hello and a very warm welcome to this NOI Group clinical discussion. My name is Joanna Taylor and I am Director of NOI Group Europe, and I'm joined this afternoon by NOI Group teacher and my very good friend, Dr Ben Davies. Welcome back, Ben.
Hi, Joe.
Hi. So for those of you who have missed our previous sessions, Ben is an advanced practice physiotherapist specialising in persistent pain and rheumatology. He brings over 15 years of experience teaching pain science with a gift for making complex neuroscience accessible and immediately applicable. So Ben, great to have you back. Would you just be able to remind everyone a little bit about what you are doing currently in your work?
My job is at the Royal National Hospital for Rheumatic Diseases in Bath. It's a hospital that's been around for around 300 years, though it's part of our District General Hospital now, the Royal United Hospital in Bath. And I run a residential programme for axial spondyloarthritis. So a particular rheumatology condition that leads people to be stiff with extra bone growth, and people come here for 2 weeks and they get daily hydro, OT input, psychology input, physio input, medic input. And it's the only one in the UK. In some ways, I think it's the only one in the world, really, so for this condition. So it's quite unique and very rewarding.
Amazing. Thank you so much. These sessions are all about giving you a taste of explained pain and how to practically use it in your clinic. Some of you on the call will have already done an explained pain course, and for those of you who have, these sessions will reinforce what you've already learned. But if you're new to explained pain, this will give you a taste of what we cover in the core course. Ben has got an upcoming 2-day explained pain online course on the 19th and 20th of March. And for anybody who's interested in attending, we're going to give you some more details about that at the end of the webinar. So please just hang around and we'll talk you through what to expect if you would like to join that course. I've put the link to that in the chat. So if you want to have a little look at that whilst we're talking, then please do feel free. So just a couple of things to mention before we start. Ben and I are going to be talking for about 20-25 minutes. If you've got any questions, please pop them in the Q&A and we'll get to as many of them as we can. And if you want to watch the recording of this session, you can access it in the clinical discussion YouTube channel. The link to that is also in the chat. Okay, let's get stuck in. So today we're talking about what to say to patients with pain when they ask, "What's wrong with me?" So, what are patients really asking when they say this, Ben?
I suppose they're asking what the question says. What's wrong with me? They've turned up in your clinic with a problem and they want to know what is causing that problem. So I suppose the variety of answers that we need to have range from, I guess, the really obvious. Someone turns up in your clinic with ankle pain 3 days following an ankle sprain playing football, and that ankle is red and puffy and swollen, and they're antalgic gait, walking off weighting it. You're likely to be fairly kind of tissue specific about what the problem is. You will assess them in some way. You'll take into account their life expectancies, their comorbidities. What are they expecting to get back to? What do they need in terms of day-to-day life and sport function and work function? You'll physically assess it and you'll give them a prognosis, which for that kind of case is likely to be, by 4 weeks, you'll be like this. By 6 weeks, by 10 weeks, you'll be back to sport. You could do treatments A, B, and C. That might be paracetamol, that might be anti-inflammatories, that might be taping, that might be rehabilitation exercises. And you and the person are very much kind of on the same path. You're talking language they have an understanding of. It's coherent. Their subjective narrative, your objective assessment, the plan that comes out of that is consistent. Easy peasy. That's not the problem, though, is it? The problem is at the other end of the sort of complexity spectrum, where perhaps someone comes with widespread pain and they've seen orthopedics and they've been MRI scanned and they've seen neurology and had nerve conduction studies and they've seen rheumatology and have a bunch of blood tests and gene markers done. They've seen a raft of other physiotherapists, osteopaths, chiropractors, and then they come to you, and maybe all of those investigations are less than convincing as to what the cause is. Maybe that person's pain has been going on for months, years, decades. You've got a very different situation there. That is not a simple situation. And that's one where, the kind of respectfulness of that person's experience, the respect we have for that person's experience is crucial. And how we first engage with them, I think, is really crucial. We've got the option of saying, well, look, all of this stuff is fine. It's all normal. Don't worry about it. I suppose, think to yourself how if you've got a problem and someone goes, just don't worry about it, that's all fine. It'll be quite easy to feel quite disbelieved, unheard, unvalidated. It's unlikely to get that sort of relationship with your patient off to the best start. How do you say, okay, thanks for bringing all those letters, thanks for all those reports, it's really useful to see all these scans. Let's think about how we make sense of all of this. Sense making, aiming to be as coherent with a story that is consistent between their lived experience, their experiences, their understanding of all of these other consultants, clinicians, your understanding as your profession, and then what you've got to offer that person. It's that consistency of stories. The consistency of that story is really crucial. And the outset is, you get that wrong, you've lost them.
Yeah. So what you're saying here is that offering validation and reassurance and the possibility of a framework and hope is going to shape their entire recovery journey from the outset.
I think when you've got those complex people, one of the takeaways from this session that we're going to think about, one of the takeaways might be, how do we frame what other clinicians have meant, however that other clinician has written their letter, their reports, how the patient has heard from other clinicians. I often think our job in this sort of explain pain world or explain pain informed world is a bit of making sense of and translating from orthopedic speak, from neurology speak. We're kind of translating what those letters mean, what those words, those clinicians have meant, without disparaging it, without saying, oh, that clinician doesn't know what they're talking about, because the patient has also put some trust in that clinician. So I think it's really important that we give due respect to the breadth of experiences people have had from other clinicians, but we're trying to kind of translate and bring together a coherent, like you said, Joe, framework. Now, within that framework, there will be things that nobody can change that might be contributing to pain. And I think this is, for your first question, or the patient's first question, what's wrong with me, suggests causation, doesn't it? It suggests there is one thing that is leading me to have this pain experience. Can you find that one thing? Often in these situations, we're perhaps thinking about contributions. What contributes to this pain experience? What in this person's experience, life, health, emotional status, what's increasing the likelihood of that person having pain? What are the factors that are reducing the likelihood of that person having pain? Now, some of those things, if we just think about the kind of like pain likelihood, some things are unchangeable. If that person's had surgery, if that person has a diagnosed rheumatological condition, if that person has something like diabetes uncontrolled that's creating some neuropathy, those things are sort of, they're there. We can't alter them. We can't change their age. But other things are changeable. And for most of the clinicians on this call will be therapists of some kind, physios, OTs, osteopaths, nurses, psychologists. We've all got our own unique bit of the person that we would look to move and sort of shift. And I think being able to be prognostic with somebody, it requires us being clear to say, look, these are the factors that are increasing the likelihood of you having pain that are either not changeable, or they're not changeable by me, but they might be changeable by my colleague of a different profession. These are the contributors that are changeable. Fitness, psychological flexibility, improving glycemic control, perhaps diet, sleep quality, relaxation strategies, coping with stress. These are things that maybe I've got some sort of gift to help you develop.
Yeah.
And it's having that sort of balance then.
Yeah. Fascinating. Thank you, Ben. That's a that brilliant answer. Really comprehensive. Thank you. So sort of going back a little bit to when a patient does arrive with you, and they may have had some different experiences with other healthcare professionals. And one of the things that we often are asked about is how to handle it when a patient comes to you and you've got normal scans in front of you, and they've been told there's nothing wrong or it's all in their head, and then they're sat there in front of you. Why is that a problem? And as a clinician, what can you do to sort of re-navigate that conversation in a better direction?
I think it will slightly depend on the person, it will slightly depend on your setting, but I think we should everybody in this call should have skills to kind of go, okay, so you've got a normal MRI scan. Let's have a look at that reading. Now you're in your 40s, 50s, 60s. Those phrases, degenerative changes, what does this mean? What are MRI scans good at showing? They're really good at looking at structure. They're really good at looking and excluding the nasty. So let's forget that, let's read that report. There's no tissue fractures, there's no cancers, there's no tumors, there's no signs of serious pathology. But also, what do scans not show? They don't show you moving. And I think crucially, and this is a point I almost always make to people, is they don't show pain. They don't show pain. They only show structure, and structure and pain are not well linked. Some structural changes might well be linked. If someone's got a massive disc bulge and they've got absent reflexes at a level that's consistent with that disc bulge, and they've got a history that suggests, then there will be some increasing causation from that disc bulge. But when it's normal and everything's just sort of age related, help the person understand that this is what an MRI scan shows. It's really good at this, and we should take all the positives that you don't have cancer, you don't have osteoporotic fractures, you haven't got disc bulges, but you have some age changes. That's normal. It doesn't show pain. Maybe from a neurology perspective, nerve conduction studies, when they put needles into your nerves and they ping electrical impulses, they look for the speed of conduction. It's working, fantastic, you're connected. That's consistent with my neurological assessment of your reflexes, but it doesn't show the fact that your nervous system is actually carrying or propagating more messages than it needs to, this idea of sort of neural hypersensitivity. So when I push on your nerves, this is a slightly different test. You're really jumpy. We might do tests that load the nervous system, and you might get that arm pain or the leg pain. It's unpicking for the lay person that nerve conduction studies, again, they don't report pain. They don't show the nerve's hypersensitivity. They just show speed of conduction. So the fact that's normal is normal. Blood tests, lots of blood tests are falsely normal. In AXPAR, my condition, only about 40% of people will have a raised inflammatory marker ever. 60% of them, their blood tests for inflammation are normal. What yours and I's might be less than 5. So we have to kind of know how likely is this test to be abnormal. So we've got to be able to explain to the person, and we know this as clinicians, each test, blood test, imaging modality, it's never a whole picture. It's one slice of the pie. It's one slice of the clinical picture. So how do we help that person understand which slices of the pie have been examined and what do they mean? It doesn't mean, and we may well find things in scans and x-rays and blood tests that are contributory. These contribute, those age-related changes might well contribute, but they're not the cause. What else is going to, reach that threshold that the bodily system says I need to protect, and pain is produced?
Thank you. Okay, we've got a question here from Mark. I'm just going to ask it now. Thanks, Mark. I love this question. Would you agree that the introduction of manual therapy into the treatment of patients asking this question gives them the idea that there is something wrong or dangerous going on in me, adding to their list of danger in me's, DIMS?
The interest. So just say the question again. Is it should we introduce manual therapy, or is there a risk of introducing manual therapy?
Is there a risk of giving them the idea that there's something wrong if you introduce manual therapy to the session?
I'll hold my hand up here and say I'm not like the most manual therapy person ever, and I work in a
Mm,
system situation, long-term conditions where manual therapy is pretty much not what we do. I think it depends again on how it's sort of introduced. In some ways,
mm,
it's no different to kind of the introduction of or the interpretation of an MRI scan. Are you introducing manual therapy and saying like, I'll push stuff back in place, I'll fix this for you? That has a bit of, I feel that has a bit of a risk of disempowering the person, making them feel that you're the only person who can kind of fix them. If it's
mm,
done as a let me kind of help you realize that actually your tissues are more resilient, and perhaps you do get a kind of hypoalgesic effect from it, you can then use that for exercise or other treatments. I think that's a useful
mm,
tool. But as with all tools, Mark and everybody else, tools can be used well, tools can be used badly. It's
yeah.
how we use the tool. Explain pain can be used badly, really easily badly. Explain pain ideas can be used to support the understanding from all parties as to why we're kind of working down a certain therapeutic pathway.
Mm, mm. Thanks. Thanks, Ben. So moving on from the idea of not saying it's all in your head, which I think is a big problem. It seems to be something that we get asked about repeatedly. Um, what should a clinician be saying instead of that? And what are some of the frameworks that can help patients to understand what's going on without frightening them?
Well, I might come back actually to that phrase, and this is so common, isn't it? I forget how many courses I've done, with you, Joe, 120 EP and mobilization
Yeah.
courses, something like that. Like this is, and I've absolutely got this wrong, where I feel I've said the right things, but the person hears the implication, it's all in your head. Is this a
Mm,
takeaway message? I'll address the elephant in the room up front. I'll say, look, pain is complex. So this idea of causation, contribution, pain is complex. Look, let's think, and this is going to depend on your assessment of their kind of understanding and their knowledge and their emotional health and their worries and all those things. Okay,
mm,
look, can I be really upfront with you and say, look, my take is all pain is real. Like that's my view. You do not have psychosomatic pain. There's no such thing. You don't have imagined pain. Let's like put that out there first of all.
mm,
However, I know, Joe, everybody in this call knows if they think certain things, their body will feel different. So everybody knows that actually the brain is relevant. It's not pain is in your brain, but you can kind of go, look, I can make you pain free, 100% pain free, brainectomy, pain free. There you go. Do you want that? Hard to live your
mm,
life, hard to be a parent or an employer or employee or play five-a-side football at the weekends without a brain. So brains are relevant. They're just like, I don't want you to think that I'm saying that's the only, that
mm,
it's imagined or psychosomatic. I think it's sometimes really important to just be upfront and don't skirt around it. Just be blunt and be clear. And then that person knows where you're coming from. Frameworks, though, just ask me your question again, Joe. What's a framework for helping people to understand? Is that right?
yeah, without frightening them. So, because I think that that phrase now it's all in your head has actually become it's really been a massive no-no, hasn't it? Because it terrifies your patients. So
Yeah.
how can you sort of marry what you've just said there, Ben? You can't dismiss the brain, and you absolutely and all pain is real. So how do you sort of manage that going forwards in a conversation to allow the patient to feel heard and understood, validated, without frightening them? And I know it's difficult because we haven't got a patient example in front of us, but just sort of more generally, what's your thought process as you've got that person sat in front of you?
So as on one side, there's the clinical need through a clinical assessment, clinical reasoning process to be certain that nothing has been missed. So in
Yeah.
some ways, the more clinicians that person's seen elsewhere, neurology, rheumatology, orthopedics, GPs of many flavors, primary care, the more stuff that's been done, the more we can be really certain nothing biomedically is wrong here. Nothing is, catastrophically wrong or has been missed. The more that person's been investigated, we can also be certain to say this shows that there's no concern about missed pathologies and cancers and tumors.
Mm.
I think we would then need to flip that and say, look, what is changeable here? What can we change, and how do we go about changing this? And actually, that does become a message of, I suppose, possible prognosis and hope, and engagement with certain approaches that are more likely to improve your quality of life and reduce pain, improve your ability to function. I think we have to be quite sort of honest about how we're broadly assessing that. And I think
Mm.
that, as a physio, I've done bits of CBT and other sort of psychological courses, but it's opening those questions of saying, look, I'm getting a sense that you're worried about certain things. I'm getting a sense that there's quite a lot of maybe pressure at home, or I'm getting a sense that, and that sort of inquisitiveness of just opening up those areas
Mm.
allows people perhaps confidence that that is potentially part of their picture. And if we want to be as rounded and holistic, and particularly on the complex end of the spectrum, we can't ignore those things. We can't, they may not be for us to deal with as a
Yeah.
physio,
Yeah.
but we need to be able to kind of say, look, there's this stuff. You've been really candid with me about your difficult childhood, your physical abuse you suffered as a teenager, sexual abuse, whatever it might be. I feel that's relevant for this sensitivity that we're picking up in your tissues, the
Mm-hmm.
fact that your neural system is so jumpy that you're not sleeping well, that you feel like you're on edge all the time. But that's something that if we can begin to shift it or help you deal with it, it's not for me, it's for my psychologically informed colleagues. Now the person may say, I don't want to deal with that. I don't want to go there. I've shoved it in the box and I've shut the lid on it.
Mm.
Fine. That's fine. Let's just be honest about what we can do.
Yeah.
And let's focus on that. And let's get that
Yeah.
person as fit, as strong, as flexible, as sleeping as well as they can, and all those things. If you
Mm.
choose to open that box or choose to kind of deal with those psychological things or life experiences through other multidisciplinary, interdisciplinary treatment, then you may get further towards your aim
Yeah.
than if you don't. But that's the person's
Mm.
choice. And I think it's how we frame that. I'm not blaming your experiences in childhood on you having pain. That's not caused it, but it might have contributed.
Mm. Mm.
And so,
What,
yeah,
sorry, Ben.
go on.
No, what I was going to say is that I've sat in on so many of Ben's courses, and we often get sort of detailed questions. I'm going to ask those questions in a second. Those people that put them in the chat. But we have a very limited opportunity here to talk about nuances today. But what I will just say is that in Ben's course, he goes into so many different, sort of a matrix of possibilities about things to look for, how to handle all these different elements, where your scope it starts and where it stops and what to do then. But all this whole matrix of these factors that come into the patient consultation. Ben goes through just about every single one of them. It's so detailed. So that will be the place to address those sorts of questions properly, would be on the course. But just for here today, there's a question here from Felicity. And are there any useful tips? Are there any helpful tips to using a narrative approach that can be helpful? And how would this differ from more structured approaches, e.g., pain cycle, twin peaks? And when do you go for each? I think it's going to be difficult for Ben to answer this question fully in the time, but go, Ben, see what you can do.
So, if people Google John Lorner, Launer, probably John Lorner Postgraduate Medical Journal, something like that.
Mm.
He's a GP trainer in the UK, possibly near retirement, possibly retired, but he's written some really lovely short pieces that are generally free text. around narrative medicine. And narrative medicine
Mm,
is the opposite of sort of having pro formas and having a structured question and aggravating factors. Oh, hang on a second, no, I need to ask you drug history. Wait a second. You just say, tell me your story, and you let the
mm,
person talk. 5 minutes, 6 minutes. Don't worry that they're going to go fill the hour. They won't. They will tell you the story, and that story is really, to me, it's like the kernel of being able to understand the person. And then you can like help. Oh, you said this. Can you just expand on that? The way you said that, that was quite interesting. Can you help me understand that a little bit more? He talks about kind of clinical inquisitiveness, which I think is a really
mm,
nice phrase. Just being inquisitive, because then you're building a relationship, you're understanding the story. It's not like a sort of Sherlock Holmes detective process. You are hearing a narrative, and it doesn't take long, Felicity. But I think what you then do is you kind of go, from this narrative, from my assessment, from these other letters, let's pull up the Twin Peaks model and think about why your system, like your threshold for pain production, pain experience is like lower than it was, and your
mm,
physical history, physical capabilities are lower than they were because you've had, you know, 5 surgeries in your 70s and you're osteoporotic, and you can then use those kind of ideas to kind of diagrammatize your thinking maybe, or
mm,
put on a page that you can then give to the person and go, this is kind of my thinking on a page.
mm,
There's another, I'll just give you one other thing. A guy called Matt Lowe. Matt Lowe's a consultant physio in Bournemouth. He's written some really lovely stuff on. He calls them dispositions. What predisposes you towards, or what disposes you towards pain, away from pain? And he's got a really nice idea of a vector model. You have to imagine a line, and you've got factors that go towards pain. These are factors in this story that are like dispositions towards pain.
mm,
These are
mm,
the things that dispose you away from pain. You've got a really good supportive home life, haven't you? And you've got a really accommodating employer, so you've got flexible arrangements, and you're really positive about making changes. Those are all on your side. And then you've got these things that are like predisposing you or disposing you towards the likelihood of pain. It kind of gives you this sense of balance, and it helps us maybe go, look, this stuff we can't change. You've had 5 surgeries. I can't undo that. That's there. But fitness, like that's changeable. How do you enjoy getting fit? What things do you enjoy? How can I coach you? That's a thing that can be shifted towards less likelihood of pain, lower likelihood of pain.
mm. Thanks, Ben. That's absolutely fantastic. I just want to give a shout out there to David Bolton, who has put into the chat that "tell me your story" is a beautiful and so empowering phrase for a patient to hear. David Bolton is a NOI group instructor with like 50 plus years of experience in clinical practice, and he is in the NOI group Facebook group, which I'm going to drop the link to that in the chat in a second. Do go in and join. He's always in there answering questions and just engaging with people who come to these sessions. So I'll drop the link for that in a second.
Joe, this is a
Um,
quick answer. I've just seen Tom Jordan's question. Like, am I right in thinking people with sensitization can also have some nociceptive? Of course they can. Just because someone's got fibromyalgia or complex regional pain syndrome, like, they can break a leg, they can sprain their ankle. So, Tom, absolutely. And I think this is the kind of malleability of, even though someone comes to you with decades of pain, you're not saying it's all your spinal cord that's the problem. It's all your brain that's the problem. You are having to, as a clinician, kind of go, look, there are some contributors from central sensitization, worry, anxiety, depression, but there's this in your body as well. And so how do we manage each of those? How do we not guesstimate, but how do we sort of put forward a sensible rationale of like how much of each of these is which, and how do I deal with these appropriately? And is that in my gift, particularly the stuff that's more emotional, psychological? As a physio, there's threshold. Thanks, Joe.
Thanks, Ben. Amazing. Okay, so we are just going to give some details now about Ben's upcoming course, and then to end the session, we're going to ask Ben for a key takeaway from today. So for those of you who might be interested in doing a much deeper dive into all of these communication strategies, Ben's just going to give you a little bit of information about what you might expect from his 2-day Explain Pain online course. So Ben, for people that are inspired to go deeper, learn more, how does this communication and language fit through the course?
I think the course, we think about, and it always comes to Tom's question, like, what does nociceptive pain look like? What's the mechanisms? What does neuropathic pain look like? What are the mechanisms? How do you as clinicians understand those mechanisms? How might you put those mechanisms across to somebody? Central sensitization. There's this iceberg picture. What do you need to know? It's the under piece of the water. But as a clinician, what do you need to put across to a patient? It's not the neuroscience, really. It's the sort of narrative about why they are where they are when they come to see you. So I think we kind of try and weave together neuroscience, clinical approach, key messages, then the target concepts are a kind of key thread through that course. And of course, from David Butler's research, some skills in education, thinking like a teacher, thinking like an educator. That's not something that we have probably, anyone on this call, we probably haven't been taught to be teachers. What's the curriculum for this person? How do I know where they are now? What do I need to teach them with the greatest of respect? And how do I know that they've got it? What do we see in terms of behavior change or engagement with our treatments, whatever those treatments may be?
Thanks, Ben. That's
Pleasure.
great. Thank you. We get amazing feedback from, he'll hate me for saying this, but we get 100% feedback consistently from all of Ben's courses. He's a superb teacher. So if you want to learn about Explain Pain, I can highly recommend it with Ben. So thank you, Ben. Thank you for sharing your expertise with us. So just finally, if there's one takeaway from today, well, what would that be?
On my course that we run here, we have a session on pain. It's kind of Explain Pain, but on the timetable that people get, it says pain is complex. And we have a discussion about why pain is complex. And I think that's it, really. Unpicking all the contributors, not the causation. Unpicking causation could be really obvious, the acute presentation. But the further down the line they go, the more complex it gets. Just be upfront with people. Look, this is complicated. Let's unpick these letters, these scans, these tests, your response to drugs, your belief, your Google research. Let's try and find the consistent story in this and think what we do about it.
Brilliant. Thank you so much. So thank you everybody for joining live today. Thank you for your time. Thank you for all your questions and your attention. We hope you found it valuable, and we look forward to seeing you again in the not too distant future. Thanks, Ben. Thanks, everybody. Enjoy the rest of your day.
Take care. Bye-bye.
Take care.